All right. Well, this session is DM1, what you need to know. As you know, I'm Mindy. Today's session will run 45 minutes. We are running a little bit behind time, so that's okay though. We're just gonna keep going with it. It'll be followed by Q&A. So do try to save your questions to the end. It's also important, if you can, make your questions broad as possible because Dr. Swenson can't give direct medical advice. But she's here today, Dr. Andrea Swenson. She's a neurologist specializing in neuromuscular disease, which you heard her earlier. She's the medical director for the University of Iowa Myotonic Dystrophy Clinic. So welcome, Dr. Swenson.
Thank you. Thank you so much, and thank you guys for coming out today. These are my disclosures. Learning objectives for this presentation include recognizing the prevalence of DM1 in the community, understanding the signs and symptoms of DM1 and which body systems are affected, and learning the genetics underlying DM1 and describing disease management, focusing on symptom control and enhanced quality of life. So, what is myotonic dystrophy as far as the name? So if we break down the name, myotonic refers to myotonia. So this is a video of myotonia. So what you see is the when we tap on the thumb, the muscle contracts and then it slowly releases back into the neutral position. So that's myotonia. And then the dystrophy part refers to muscle weakness and atrophy. So in these photos, you can see loss of muscle bulk throughout the forearm as well as down within the leg. There's two types. We're talking about type 1, which the old term is dystrophia myotonica type 1, DM1, and then type 2 is dystrophia myotonia type 2. So even though we call it myotonic dystrophy, the DM1 and the DM2 references have kind of stuck around. But you need to be careful because in the general healthcare system, if you mention DM1 or DM2, a lot of times people are going to think you're talking about diabetes type 1 or type 2. So not many people think of myotonic dystrophy when they hear DM1 or DM2. So other terms, you might hear the term congenital myotonic dystrophy, and that is type 1 with the disease starting as an infant. Also, Steinert disease, that term isn't really used that often, but it refers to the physician Heinz Steinert who described the first cases recognized as myotonic dystrophy. And then for type 2, you might hear proximal myotonic myopathy, or PROM is another term for that. So myotonic dystrophy is the most common muscular dystrophy diagnosed in adults. Even though it's the most common muscular dystrophy, it is a rare disease. About 1 in 2,100 people have the DM1 genetic mutation within the US, and that comes out to about 140,000 people with DM1. So it is not that common. The prevalence is the same in men and women, and we'll talk about that a little bit later on. So signs and symptoms of DM1. This is a multi-system disease. That means multiple organs in the body are affected by DM1, and this results in the many unique symptoms that people experience. Most people will notice symptoms beginning in their 20s or 30s. The symptoms do progress over time. And I have a lot of different things listed in this picture here, and we'll go over each of those symptoms separately. When thinking about symptoms, it's really important to remember that not everybody experiences all of these symptoms, and that people will have a varying degree of symptom severity. So the muscles are involved. This includes skeletal muscle, cardiac, and smooth muscle. So the skeletal muscles are going to be the large muscles in your arms, legs, face, neck. Cardiac refers to the heart, and the smooth muscle is found within your GI tract. So that's the esophagus, stomach, intestines, bowels. Those are the muscles that keep food moving through our bodies. So we have conscious control over the skeletal muscles. We can make them do what we want them to do, but the heart and the smooth muscle, we don't have conscious control over that. Those things contract automatically. So skeletal muscle, just change these videos here. So the symptoms that people experience with that are myalgias, which refers to muscle pain or muscle tenderness. And we mentioned the myotonia, where the muscle contracts and then slowly relaxes instead of relaxing quickly. This video is showing grip myotonia. So the person is asked to squeeze the fingers really hard and then to release quickly. But you can see it's hard for them to get their fingers released fast and straightened all the way. So when we hear myotonia, a lot of times we talk about it in the hand or with grip myotonia, but really myotonia can happen with a lot of other muscles. And that's why I wanted to bring this photo up here. This is an example of tongue myotonia. So tapping on the tongue, you can see a part of the tongue kind of squeezes inward or kind of pulls in, and then it's slow to relax back into the neutral position. So myotonia can be in a lot of different muscles, but oftentimes we're talking a lot about within the hand and grip myotonia. Weakness is a part of myotonic dystrophy. With type 1, it's a distal weakness, and that means weakness in the hands, trouble with gripping things, and also foot drop. So foot drop is difficulty pulling the toes up, and that can make it hard to walk, and sometimes people feel like they're slapping their feet on the ground when they're walking. Over time, proximal muscles can get involved, and these muscles are responsible for raising our arms above our head or helping our legs stand up out of a chair. Facial muscles can get weak. So the muscles along the temples on the side here can also start to get weak and atrophy or kind of get smaller. And that can cause kind of a sunken look with the temples. Ptosis is due to weakness of the eyelids, and that can cause the eyelids to droop or kind of cover the eyeballs. And then also eye closure weakness. So when people try to really squeeze their eyes shut tightly, it's hard to do that. Occasionally, the respiratory muscles can get weak, the diaphragm, the chest wall muscles, and that can cause shortness of breath, particularly with exercise or exertion or lying flat. The heart is involved in myotonic dystrophy. I included this photo here, which is from a brochure online that was put together by a myotonic dystrophy support group out of the UK. And it's a really nice brochure going over the cardiac issues. And I also included the photos from that brochure here as well. So what does the heart do? It's responsible for pumping blood that contains oxygen around the body. And then that blood gets up back to the heart, and then the heart pumps that blood that now has carbon dioxide in it into the lungs to get exchanged for oxygen again. The heart depends on its rhythm. So this is synchronized pumping of the 4 chambers of the heart, and it's controlled by the heart's own electrical system. So this photo is like cutting the heart in half and looking at the inside. There's 4 different chambers, and this is all surrounded by muscle. And within the muscle, there's the electrical system that causes the heart to pump. So the cardiac concerns with myotonic dystrophy center around arrhythmias, and that means an abnormal rhythm. So either the heart is beating too fast, too slow, or irregularly, or sometimes the heart can get blocked and that rhythm doesn't continue through the entire muscle of the heart. Symptoms people might notice include palpitations, and that feels like funny heartbeats in your chest, or you can feel your heartbeat in your chest. If the amount of blood pump to the body is not enough, which can happen in these situations. People might notice that it's difficult to exercise or they feel short of breath. So the heart to pump well really relies on that rhythm being in a synchronized rhythm. And if that's not there, the pumping of the heart just doesn't do what it should do. And also, if there's not enough blood that's getting up to the brain, that can cause people to have episodes of passing out or blackouts. So those are some symptoms that people might get from heart issues. The other thing is that sometimes people don't notice symptoms at all. And that's why it's really important to get heart testing done, even if you're not having any symptoms, because sometimes the heart testing might show that there's arrhythmias or abnormalities in the heart, and people might not be having any symptoms with that. So the arrhythmias can result in sudden cardiac death. But there's been so many advances in cardiology as far as medications, devices, that we've really been able to make a difference in preventing sudden cardiac deaths. So cardiac monitoring is super important to pick up on any of these abnormalities. With the GI tract being affected, people might notice abdominal pain or bloating sensation, constipation, diarrhea. There can be gallbladder issues. Some patients actually have to get their gallbladder removed. And they can notice some dysphagia, which is difficulty swallowing and may result in some choking. With significant trouble with swallowing, people can get aspiration, where the food and liquid goes into their lungs and can cause pneumonia. Cataracts is a part of myotonic dystrophy. So what happens with cataracts is the lens of the eye gets clouded. And oftentimes this doesn't cause any visual problems. So again, another important reason to get screened to pick up on these things. If the cataracts remain in the eye and are not taken out over time, people might notice some vision impairment. The cataracts found in DM are most often going to be picked up at a younger age, like below 55 years. And everyone with DM1 will get cataracts eventually. Fatigue and sleep disorders can be part of DM1. This can result in daytime sleepiness, feeling really fatigued. Those are very common symptoms. Somnolence for people who require more sleep than what is necessary can be quite bothersome, as well as sleep apnea, which can result in poor quality sleep and snoring. The effects on cognition or thinking from DM1 are variable. A lot of people don't notice any cognitive impairment, and there are some people who notice or who have intellectual disabilities that require special education or individual learning plans for their school and occupations. Patients may have an avoidant personality where they prefer not to be in social situations where they might be subjected to criticism or feel embarrassed. Apathy or lack of interest or initiative in activities. And also there's a higher risk for depression in DM1. Other systems that get involved, insulin resistance can result in type 2 diabetes. There can be thyroid dysfunction with hyper or hypothyroidism, high triglycerides and high cholesterol, primary hypogonadism in men, which results in low testosterone, testicular atrophy, and can lead to infertility. There have been reports and kind of more research developing in the area of cancers in DM1, and there is a higher risk of developing cancer, particularly with melanoma, which is a type of skin cancer, thyroid, colon, and uterus. The recommendations at this point are just to follow age-appropriate cancer screening with your primary care doctor. So there aren't any recommendations beyond that, but it is something that we stress to people to make sure they have a primary care provider and that they're up to date on these screenings. There's some consideration in getting a thyroid ultrasound, but this test can be a little bit tricky and sometimes hard to interpret. There, as was mentioned earlier, there is caution with anesthesia for surgery. It's okay to get surgery, but before you do, make sure your surgeon and the anesthesiologist know about DM1. There's a lot of great resources on the MDF website that you can show your doctors about, and then they can follow those guidelines to make sure things go easier during surgery. So there was a study that I believe there were close to 1,000 people who were in this study asking about the first symptoms that they noticed with DM1. And they asked about a lot of different symptoms. And the most common first symptom that people reported is grip myotonia, or that stiffness in their hands. That was about 40%, arm weakness, 20%, and general weakness and leg weakness were some of the more common first-time symptoms. So to understand myotonic dystrophy and the symptoms that go along with it, it's helpful to get a better understanding of the genetics behind it all. These are some questions that we get from our patients in clinic. How does someone get DM1? Why do some family members have DM1 and others do not? And why are the symptoms of DM1 variable even within the same family? So we'll go over some things and try to answer these questions. So how does someone get DM1? So to this, we need to turn to the genetics, which is the study of how genes and traits are passed down from one generation to the next. So DNA, which is part of this, carries the blueprint for our body structure and gives instructions for our body's organs to function properly and maintain. Each gene codes for a protein that is essential for a specific bodily function. And within each of us, we have 25,000 genes. These genes are on chromosomes, which are tightly condensed sequences of DNA. And human cells have 23 pairs of chromosomes, so a total of 46 chromosomes. One set is passed down from each parent at birth. And this here is all of our chromosomes laid out flat. So there's 22 pairs of autosomal chromosomes, and there's 2 sex chromosomes. So XX is for female at birth, and XY is male at birth. Looking at all the chromosomes here, the one that we want to zero in on is chromosome 19, and this is where DM1 starts out. So to understand that, we need to talk a bit about the central dogma of biology. So the DNA, the blueprints, that's transcribed into RNA, which is translated into proteins that are essential for everything within our body and everything that we do. So what is up with chromosome 19? That is where the DMPK gene is located. So DMPK stands for Dystrophy Myotonica protein kinase. And this plays an important role in our muscles, our heart, and our brain cells. So if we look a little bit closer at the DMPK gene, we see that there's a section that has repeats. So what are repeats? Well, genetic code is filled with a series of letters, which are the nucleotide bases. In some genes, there can be a section where a letter pattern repeats itself. So in the DMPK gene, it has a section with CTG repeats. So looking at this diagram, you can see CTG, CTG, CTG. So there's a lot of that repetition. And that's normal. Normally, there's going to be anywhere from 5 to 34 of those repeats. However, with myotonic dystrophy, there gets to be too many of those repeats. And that's called a repeat expansion. So a huge increase in the number of repeats. What goes wrong when the repeats expand or get increased? So with DM1, there's going to be anywhere from 50 to thousands of these repeats. And like we talked about, that DNA needs to get transcribed into RNA. So that does happen with all of these repeats, but this is where the problem lies. Those repeats, instead of making the RNA that we can then move into a protein, that RNA is not what it should be, and it becomes toxic. So that toxic RNA leads to problems in our chloride channels, which then causes the myotonia. It affects our insulin receptor, which can lead to diabetes, the calcium channel, which can lead to muscle disease and weakness, and the sodium channel, which can cause the cardiac arrhythmias, all leading to DM1 and the multisystem disease. Also, what's happening is that this RNA that's doing what it shouldn't be doing is clumping up in the cells. And these clumps, instead of helping out with our regular functions, cause dysfunction within the cell. Also, important proteins get trapped in these clumps, and those proteins can't do the things that they need to do. One example is muscle-blind-like protein, which is something you might hear about when we think about potential medications that can help this process. So remember this slide because this is going to come up again. So why do some family members have DM1 and others do not? DM1 is inherited in an autosomal dominant pattern. So that means that one copy of a mutated gene is passed down from one parent, and that's enough to cause DM1 in that child. Each child has a 50-50 chance of inheriting the gene mutation. So that is for each child has the 50-50. It doesn't mean that half of a person's kids will get DM1 and the other half won't. A parent with DM1 may pass this on to none of their kids, maybe pass it on to just a few of their kids, or it could be all of their children that get the mutated gene. Why are the symptoms of DM1 variable even within the same family? There's a lot of different factors to this, and we'll go through those. So one of them is called anticipation. Anticipation means that the number of repeats will increase in a child. So so the number of repeats in the parent is not going to be the same as that in the child. And this has to do with the stability of the repeats. So when the repeats are in the normal range, they're pretty stable, meaning that, for example, a parent's repeats might be 10. Their child's repeats are going to be 10 as well. However, with myotonic dystrophy, those repeats are not stable, meaning that they can increase with the next generation. So for parents' repeats that are 50 and above, their child's repeats are going to be more than the parent's size. And the repeat size does have an effect on the age of onset of disease as well as how severe the disease will be. So if we look at the repeat size, normally 5 to 34 repeats, there won't be any DM1. There's also something called a pre-mutation, which is repeat size from 35 to 49. And if people have that, they're not going to get DM1, but they do have the possibility of passing an even higher repeat size onto their child, who then will get DM1. So with this diagram and just looking at the numbers, if we look all the way out here, that's repeats 1,000 or greater, and that will be congenital onset. So infants will show symptoms of the disease. And then milder disease is going to be in the 50 to 100 range, and a later onset. And then in the middle, we have classic adult onset and then childhood onset. One thing to take note of is there is some overlap in these repeats. So that probably doesn't explain the whole story because some people with mild disease may have a similar number of repeats as people who've had more severe disease and an earlier age of onset. So here is a photo from Andrew Engel's myology book. It's a family showing anticipation. So the grandmother looks like she has mild symptoms. With the mother, you can start to see more facial weakness. And the child has congenital myotonic dystrophy, which with facial weakness, and it looks like probably some neck weakness with difficulty holding their neck up. So just for an example, these are not the actual repeat sizes from this family, but just to kind of show you what this could look like. The grandmother could have a repeat size of 82, and then her daughter, it increases to 250, and then with the grandchild, 1,000. So another explanation for variability within myotonic dystrophy is called somatic mosaicism. And this means that different types of tissues within a person's body can have different numbers of repeats. So for example, the number of repeats that are found in muscle cells, muscle tissue, is going to be much higher than what the number would be in that person's blood. Not only that, but even within the same tissue, the cells can have different repeat sizes. So this is a picture of a muscle biopsy. So each one of these areas here is a muscle cell. And this is just an example of what that could potentially look like. The muscle cells have different repeat sizes, even within the same tissue. And the number of repeats increases with age. So those are some things that probably play into why we see variability within how the disease presents with its symptoms, and may not entirely match up with what we would expect with a person's number of repeats. Other things that can affect variability are the things that we think about when we look at all of us. Everybody's different. We all have our own genetic DNA code. And so those are things to think about too. There's probably other genes that are having an impact on what an individual person's DM1 is going to look like. We also have to take into consideration environmental factors because those can have an impact on the course of any type of disease. So getting back to our questions, how does someone get DM1? It's from the expanded repeats in the DMPK gene, which leads to RNA toxicity, which then causes the disease. Why do some family members have DM1 and others do not? There's the autosomal dominant inheritance pattern where each person has a 50-50 chance. So some family members will have it and others will not. Why are the symptoms of DM1 variable even within the same family? We can attribute that to anticipation, the repeat size, somatic mosaicism, and other factors. So DM1 management, the first place to start is to build your team. And here's a photo of our multidisciplinary clinic team with our physicians, nurses, and therapists. So the team managers, you want to find a neurologist who can direct the care management regarding DM1. It's really important to have a primary care provider for at least annual checkups to manage other medical issues. As was mentioned earlier, DM1 is a rare disease. Primary care providers are experts at taking care of common diseases, but there's so many rare diseases out there that they just won't be able to have expertise in all of them. So you want to have a primary care doctor who is willing to learn about myotonic dystrophy and to work with you, even though they're not going to be an expert in it. But it's really important to establish that relationship. And then seeing a dentist, that's important as well. So just to kind of run down the the list of physician team members. So the neurologist will be the one diagnosing DM1 in most cases. They can manage the care plan and also treat symptoms that come along with DM1, like the myalgias and bothersome myotonia. The primary care provider, they're the ones that you want to see for your overall health, as well as being involved in the age-appropriate health screenings, including the cancer screens, and can also help out with any GI symptoms. The cardiologist, this is a very important person in your care team. They will be doing EKGs to look at your heart rhythm, as well as echocardiograms to see what the heart structure looks like and how well it's pumping. And they also will assess if you need any interventions like a pacemaker. An ophthalmologist to evaluate your eyes. They can screen for and remove cataracts. A sleep specialist to help with sleep hygiene. If you need non-invasive ventilation for sleep apnea or to help with respiratory muscle weakness. And then also with the daytime sleepiness, sometimes people will use medications like stimulants to help with that. Here's a list of the therapy team members. The physical therapist can evaluate strength and walking and develop an exercise or activity plan. Exercise and activity is very important in DM1 to help with overall conditioning. They can also help address any bracing or mobility needs. An occupational therapist can help with hand function as well as assessing activities of daily living. A respiratory therapist will measure breathing tests. A speech therapist for people who are having trouble with swallowing, they can recommend foods that are easier to swallow and also evaluate for any speech changes. A genetic counselor to help explain genetic testing results and also help families identify other family members that might be at risk for DM1, as well as helping with family planning. A mental health counselor for emotional support, mental well-being, and coping. And a social worker who can help with any questions about disability, school or work accommodations, and can help set up healthcare resources at home. So a lot of people in our clinic ask, what can I expect? What are some things I can do? And when will I need certain pieces of equipment? Again, when thinking about this question, it's always important to remember how variable myotonic dystrophy is, and that not everybody is going to need every piece of equipment. But there was a study that came from the registry at the University of Rochester. They send out yearly surveys to the participants to see how they're doing and kind of what their equipment needs are at that time. And if we just look at the age 60 and think about at what point people are requiring certain interventions, by age 60, 25% of people were using ankle braces, 35% using a walker, 20% using wheelchair, 24% had a pacemaker placed by that time, and 30% were using non-invasive ventilation like a CPAP or BiPAP. For sleep apnea or respiratory muscle weakness. So what can I do? I think one of the most important things you can do is really get to know DM1. There's a lot of great resources out there. You heard about them earlier this morning. The MDF has a wonderful website with so much information on there. It's really, really important for you to get to know that this is a rare disease and not many people have even heard of DM1. So it's really good for you to get to know the disease better. Building your healthcare team, identifying your goals, and make sure your healthcare team knows about them. So I think this is an important piece because sometimes your healthcare team may assume you have certain goals for your care, and those are totally different than what you're interested in doing. So make sure you express that to your team. Focus on your health. So one of my colleagues in our neurology department really likes to talk about NES, or nutrition, exercise, sleep, and stress, and how you can apply this to any disease process. So that's one thing that we can all work on that has benefits with whatever disease we're addressing. And reach out for support. I think with rare diseases, it can feel very lonely and isolating, but this is a very well-supported disease. The MDF has a lot of resources and a lot of networking, so definitely reach out for support. So that's all I have for this, and I think we'll open it up for questions.
You said the RNA is toxic. In what way do you mean it is toxic specifically?
Yeah, that's a great question. So normally the RNA is going to be translated into proteins, and that's kind of the normal process. But with this RNA, instead of going through that, it just starts to clump together and really doesn't allow for the normal process of things. So when it's clumping together, it can be stuck in cells, and when it's stuck there, it's something that really shouldn't be there. And for a cell to work normally, it needs to have all processes in place. So with that RNA clump just sitting there and hanging out, it's going to cause dysfunction in the cell. And then not only that, but those clumps will take really important proteins and trap them in there. So the proteins that are supposed to be going off and building our organ structures and maintaining everything else are just trapped. And so in that way, that's why we feel it's toxic and not a healthy process whatsoever.
You were talking about muscle strengthening and keeping muscles strong, and I'm wondering if there's any downside to, working to keep your muscles strong.
That is a great question. So in our clinics, we talk a lot about exercise, activity, but doing it in a way that is safe and a way that is conserving energy. So there are times where we could do too much exercise that would be detrimental. And where I've seen that become a problem is if people are trying to do something that's too hard for them to do and they fall and break a bone or break a hip. And then that is a huge setback. And so people can actually lose quite a bit when they're immobilized for so long with a broken hip. But the important things with exercise is flexibility, so keeping our joints mobile, and then also preventing deconditioning. So any muscle that's inactive, no matter how healthy it is going to be susceptible to deconditioning. And that can make people feel even weaker than they actually are. So with weak muscles, it's always going to be tough to do a ton of exercise, but we encourage people to do what they can do to try to prevent at least some of the deconditioning that can occur.
You talked about the tests or the annual checkups that your primary care physician could do. In many health systems, ours included, they want the primary care doc to be sort of the quarterback of all the specialty care. And so we're working to get our primary care doctor dialed in to have regular testing for myotonic dystrophy type tests. This may be a tricky question for you, but what tests would you recommend be completed either annually or every 2 years?
Yeah, that is a great question. And I think some of that might depend on the health systems that our people are in and what their primary care providers feel comfortable with. What we've seen a lot of the PCPs around our area do is yearly screening for things like diabetes, thyroid and looking at cholesterol levels, at least doing those daily. And those are pretty routine across the population, but those are also really important things in DM1. One thing that I do feel like our PCPs are good about is the age-appropriate cancer screening. And so that is something that will be there for everybody. So that's an really important piece for DM1 especially. And then skin exams. I know some primary care doctors are really good about doing those every year. But that will be an important thing too, looking for any signs of skin cancer. I feel like that can be achieved at the primary care level, but sometimes people feel like it's more important to have dermatology do that. But it really depends on the healthcare system you're in and how comfortable your primary care provider is with all that. So I think that with DM1, people should be seeing a cardiologist. The cardiac conditions that go along with DM1 can be pretty complicated, and I feel like that would be challenging at the primary care level. At least people should get an EKG and an echo on a yearly basis, if not through cardiology. But in our practice, we are getting everybody to cardiology.
So you said daytime sleepiness is common. Is insomnia common? Because like at night, I can't sleep at all.
Yeah, that's a great question. Yes, it absolutely can be part of the sleep problems. So with insomnia and what causes it, there's probably a lot of different factors contributing. With myotonic dystrophy, the circadian rhythms might not be what they should be. And the circadian rhythm is what controls our ability to sleep during the night and be awake during the day. So if that is off, people might find that they're sleeping at odd hours or they're awake in the middle of the night. And then other things too, if people are sleepy during the day, they might take naps during the day, and that might affect their ability to sleep at night. With daytime sleepiness, sometimes patients will be prescribed stimulant medications, and those can be a little bit tricky as far as what time of day people take them. We've noticed sometimes if people end up taking those later on in the day, then it can really affect their ability to fall asleep at night. And then other things that can go into play, if people do have muscle pain, it can be hard to sleep with that too. So that might even add to the insomnia. So it's a lot of different things that play into that.
Okay, I think we have one or two more questions next.
Yes, I don't know if you can answer this or not, but when I was on the Myotonic Dystrophy, website or whatever, some of the patients talk about repeats. What are those?
Yep. So the repeats refer to the abnormalities in the gene. So within the DMPK gene, normally there's 5 to 34 repeats, which is a segment of the genetic code that it is the letter CTG, and that just repeats itself. But with myotonic dystrophy, those repeats increase quite a bit. And when the repeats increase, it causes problems with that gene, and then that leads to myotonic dystrophy.
Regarding the repeats and the testing, you mentioned that it could increase as you get older. So should the patients get testing again to see if the repeats have gone up?
It's not something that we recommend because there isn't anything that we would do with that number. Now, you might see that being done in research studies because they'd want to track what that number is or what it's doing. But in the clinical setting, we just use that test for diagnosis. And typically it's just done once, and it's not going to make us change our management if we test it again.
All right, awesome. Thank you, Dr. Swenson.